Good evening, everybody. So, I'm just going to highlight some of the points which I normally do when I face this problem. So, when you recognize, what do? You need to regain your control and then react to that. So, I'm not going to bore you with videos of PCR and how it is going to be managed, because my co-speakers have a list of topics wherein they'll very well cover all these areas of how to really work on these patients. But normally these are the areas where we get a PC rupture, right? Either it is at the terminal end. We're going to almost finish the phaco. The last bit of the nucleus is there, and you suddenly emulsify the capsule also with that bit. Or you're doing an irrigation aspiration with your normal irrigation aspiration cannula, and your subincisional cortex is the criminal there. Very rarely it can happen if you're vigorously polishing your posterior capsule, or rarely it can even happen during hydrodissection and the initial stages, or in the late stages like in implanting an intraocular lens, wherein suddenly your lens jumps out from your injector or something else, which really damages your capsule to have a posterior capsular rupture. So I just want to share what are the 10 things which normally I do so to manage a PCR. So first, I think the foremost important thing is you need to recognize. So early you recognize, better the results. So what are the things which they teach or normally you see in textbooks, but you can normally feel also on your surgical table, is the chamber suddenly becomes deep, or in a previously small pupil will suddenly jump and dilate in front of your eyes, or there may be a pupillary peaking. You will think, let me ignore it for some time, let me continue the phaco, but by the time you ignore it, the rupture is quite big enough to even sometimes lose your fragment inside. Sometimes it can vanish in the view, which you can see on the video. Can you click on the video for me? So sometimes the fragment can vanish from your view, but it is too late. When it vanishes like that, it is normally too late. You have to little bit recognize at an earlier stage. So for people watching, it may be a nice horror movie to see, but for us in the table, I think definitely we'll feel bad. So the next thing is you need to regain control. When you have a problem like this, you need to really regain control. Just focus on what has happened, where it has happened. More than why it has happened, it's already happened. But now, where exactly it is, and see that a kind of a calmness sense in your theatre. This is the time when we become a little bit tensed. Your adrenaline is pouring in. There is a lot of sweat around it, and you'll maybe trying to scold your paramedical or somebody on the theatre inside, which your patient under a topical or under a anesthesia is very carefully listening to you. Whatever you are saying there, they are really listening to it. At a end, there is a nucleus drop or something else, they are listening to every bit of it. So just adjust your posture, refocus not only the microscope but also your mind into the case. Don't blame anybody. Kind of communicate a calmness and order in the operating room. If you do all these things, I'm sure the management options will come in your way. The patient or the table or your experience and the skill will let you know what next to do. So the third important thing is to react. So the reaction will go for the next 7 steps. So first thing what we should do is stop doing whatever has caused the problem. For example, if you are irrigating with your phaco or an irrigation aspiration cannula, stop the irrigation. That is the most important thing. Because once you start irrigating into the vitreous hydrates and your problem becomes more and more worse. If you are aspirating again, stop that aspiration, because it enlarges your rend and it drags on your vitreous. So vitreous can come into anterior chamber or into your tunnel and things like that. And before even removing the tip, if you can recognize it, that you have a PCR, and before even getting out, immediately you can use something like a kind of a dispersive viscoelastic really to push the vitreous back, seal that area where you have the posterior capsular rupture. So this again helps you to resist aspiration and of course it may not be easily burped out of the eye also. So try to use a kind of dispersive viscoelastic there. So even if the viscoelastic is left behind after the surgery, it may cause fewer complications, and even the problem of raised intraocular pressure may not be there. Assess the extent of PCR. This is a very important thing. So depending on that, your options of managing the epinucleus or the cortex, implantation of the lens, everything matters. So see the location and the size of posterior capsular rent, and then the extent of vitreous prolapse. See the amount of lens which is remaining behind. What amount of lens, whether it's the last bit or we have a considerable nucleus or epinucleus around it. So depending on that, your management options can change. And more importantly, conditions like this decide that there is no emergency. There are two kinds of emergency. One is a kind of an ocular emergency, wherein you have an expulsive hemorrhage, which may also have a similar picture. Suddenly the shallowing of the chamber, and then your pupil will dilate and you will see a white reflex happening with the posterior capsular rupturing and everything coming out of the vitreous. So this is one kind of an ocular emergency which you should keep in mind. See that that is not there. And the second is pulmonary emergency, which again we try to sometimes ignore. The patient is coughing, or there is a kind of a pulmonary edema which is setting in. If you can recognize that earlier, not only you save the eye, but you can even save the patient. So this is the step wherein I'm just dealing you on two sides about the removal of lens fragments on your left side and cortex aspiration on your right side. So there are various ways depending upon the fragments which you have. The later speakers will highlight more in detail, but there are various ways of dealing in it. If there are a lot of lens material, there are different ways. The best way is to put in something like a glide underneath the lens and then emulsify the nucleus, which I don't do that, but there are people who practice it and they feel that it's a very good technique to do. There's one thing which I try when there is something which is getting dislocated or in a nucleus wherein it's sinking, but still in the kind of just behind your posterior capsule in the kind of anterior vitreous, you can do a posterior assisted levitation, wherein you can trap the nucleus with it's called the visco trap. You use the dispersive viscoelastic and you trap the nucleus there, and then you can push the nucleus into the anterior chamber again through the pupillar area, through the whatever rent you have caused, and then continue with your phacoemulsification. This is called a technique which is well described and textbooks and well published, called the visco trap technique. But once you feel the nuclear material is no more in your sight, or it is behind the anterior vitreous, the mid vitreous or somewhere behind it, no point in touching it beyond that. So if you do any manipulation beyond that, I'm sure your other complications is going to be there, and you're going to be there with the patient for the rest of the life. The other important part, when you have epinucleus and cortex, if there is not much epinucleus, you are safe. Again, you do a kind of a controlled vitrectomy, you clear the vitreous, and then the cortical matter can be very nicely removed. So I strongly recommend doing a bimanual aspiration in any case where you have a PCR or a Zandler dialysis. The main reason is that you need to keep the fluid away from where the vitreous is. If you can do that, you can very safely remove any amount of epinucleus and cortex. So keep your fluid away and try to aspirate from the area where it is really clear, where you don't have the rent. You remove all the cortex there, and then you gently come to the area where you have the posterior capsular rupture. It's very important. Again, the basic: grasp the anterior leaflet of the cortex and not the cortex behind the posterior capsule. So wherein if you have a small pupil, again I recommend you enlarge the pupil, either by putting an iris soak, so that you can visualize all the anterior leaflets of the cortex clearly, so in your manipulations are much less, causing a better outcome. Regarding vitrectomy, again there are two schools of thoughts, but most of you here, like me, are anterior segment surgeons who would prefer to do an anterior vitrectomy. But ideally, what people recommend is a kind of a pars plana vitrectomy. If you have an option, if you are a vitreoretinal expert, the best thing is to do a pars plana approach, because it avoids the vitreous incarceration into the wound, and also it can prevent the contact of vitreous to the endotheliums. Here, basically what you're doing is you're pulling back the vitreous rather than you're pulling forward. In anterior vitrectomy, what are we doing? We're trying to really pull it forward. In cutting and aspiration, you're pulling it forward towards the tunnel or your section wherever you're doing. But in the pars plana, it is more a controlled approach wherein you're pulling behind, you're not pulling forward. So if there is an option available, I would strongly recommend you can do that. And always avoid traction on the vitreous. So use a high cut rate and a low vacuum whenever you do a vitrectomy. Keep that in mind and see that that calmness is going to help you all through. So wherever I am talking all these steps, see that you are calm, you are composed, and your paramedical is also calm and composed, assisting with you in all these steps. So if you do all this, I am sure you will not extend the area of posterior capsular rupture and see that you can do away with minimal vitreous there. Implanting the lens, again, depending upon the support, the implanting the lens can change from place to place. If there is a small PCR, of course, we can all put the lens into the capsular bag by converting the PCR into a capsulorhexis, or by just leaving it alone and then putting it inside the capsular bag. But if the rent is quite big enough, wherein your rim is intact, wherein you have a very nice anterior capsular rim, the best thing is to put the lens into the sulcus. There is no other better way than this, and ideally it's better to use a 3-piece lens. Never use a single piece lens in sulcus. As glaucoma specialist, I specialize in glaucoma. I see a lot of patients wherein they have single piece in the sulcus and the haptic rubs on the iris and they develop a secondary glaucoma, wherein we finally amputate the haptic or remove the lens. It's a kind of a secondary pigmentary glaucoma which is reported, and we also see not very often but to some extent, especially with the hydrophobic single piece acrylic lenses. Herein you are seeing on the video is a case where normally if I have a bigger posterior capsular rupture, I do a lens as a second sitting and not in the first sitting. See, we always have a pressure that we need to implant the lens in the first sitting. But that calmness will make you more composed in telling the patient, okay, there is a problem, we have done a good vitrectomy, you have cleared our eye, your eye is still aphakic, don't worry, you're going to do a good job maybe after a week or two. This I am saying because your capsule is well fibrosed, there is a rim is well visualized when the pupil is dilated well, and you can do it as a secondary job. Your results are perfect, and you see the whole thing I just did with a saline inside the eye. You don't need to use viscoelastic, which can go behind and then cause other problems like glaucoma and inflammation. So finally you can check whether there is any vitreous in the anterior chamber. Usually use the kinolog to check that. There are again two schools of thought, I leave it to you, but we normally use it, doesn't cause any problem. And you can constrict the pupil. Again, whether it is needed or not, again it's not a mandatory, but you can constrict the pupil with pilocarpine and reform the chamber. But most importantly, I think my good friend Shivakumar will cover in detail, is talking to the patients, telling them what happened, telling them about the post-operative recovery, and then treating them very intensively with topical and systemic steroids and non-steroidals to prevent cystoid macular edema and other complications, and closely evaluating their posterior segment intraocular pressure is very important. Whenever there is an raised IOP when you have a PCR, never forget to send the patient to a posterior segment person who can really see something happening behind. Maybe a small cortical bit or epinucleus or a cortex in the vitreous. The IOP will never come down unless you remove it. So never ignore that. Whenever you have a raised IOP following a PCR, ideally you see their posterior segment thoroughly. And I just got this picture just after the Thane. I don't know who is doing a good job there, the monkey or the man. So always think of your past. When you had problem, what did you do? Why did I have this PCR? Just because it was a subincisional cortex? Okay, let me do a bimanual. Let me not do a just with the same irrigation aspiration cannula. So think of your past complications and try to avoid it. Once you have, I'm sure the rest of the team will tell you how to manage it. Thank you. Thank you.